Let me just mention two other things, if if you're not familiar with them. One, and basically, these are the way that two very critical documents call attention to the importance of work with families. So the National Strategy for Suicide Prevention, which was released by the Office of the Surgeon General and the National Action Alliance for Suicide Prevention, has Objective 9.4. And that objective is to adopt and implement guidelines to effectively engage families and concerned others throughout entire episodes of care for persons with suicide risk. And then secondly, some of you may be aware that SAMHSA's major strategic direction over the next number of years has been set by the Cures Act and the establishment of an interdepartmental serious mental illness coordinating committee. And one of the key recommendations of that report is recommendation 2.9 to support family members and caregivers. Now, having language like that in reports is important, but reports by themselves don't lead to change. What leads to change is the active efforts of committed advocates, of researchers, of policymakers, of prevention specialists, of clinicians, and of course of family members. And so we are looking forward to not only sharing information with you, but to be hearing from you about your needs. Because from SAMHSA's perspective, this is not something where we want to have a single webinar and then feel like we're done. We're hoping that this will be an ongoing commitment to working with families and the organizations that represent them to help better support them and to help better reduce suicide in our nation. So with that, I am going to hand it over to Perry.
Thank you to SAMHSA and the Suicide Prevention Resource Center for hosting this webinar and supporting an initiative to engage and support families in suicide prevention efforts. As someone who's worked for 30 years with families with a suicidal loved one, I can attest to how crucial this focus is. A supportive and skilled family environment may be perhaps one of the best resources for prevention, intervention, and recovery for those at risk. Let's first look at families as caregivers in general, where the role of families in a loved one's illness has been key for centuries. Groups exist providing education, support, a network for families living the same experiences such as cancer, autism, schizophrenia. They meet in person, online, formally, informally. These groups are lifelines for the caregivers. When we look at the suicide prevention community over the past 10 years, police, school personnel, health professionals are recognized as key in prevention, and specific trainings have become standardized for each of these groups. Families often are also first responders or serve as safety nets. They too are key in prevention and recovery. However, there has not been a specialized program that exists for families of suicide attempters. This is a missing link and needs to be considered part of best practice for suicide prevention. Families are devastated and compromised as they've experienced their own trauma from the event and often paralyzed with fear, depression, burden, grief, helplessness, anger, shame, and stigma. We see this in the borderline personality disorder community, where suicide and self-injury are hallmark symptoms. Up to 75% of self-injured and 10% of people with BPD die by suicide. Not surprising, more than 50% of their family members meet criteria for post-traumatic stress disorder from their relatives' suicidal behavior. You will hear about one program that's been helping those families. So, although family members can be a valued resource for their suicidal loved ones, they too need skills training and support. Our hope and goal is to make it standard practice to include families in suicide prevention programs. Thank you again to SAMHSA, the Suicide Prevention Resource Center, and also to our presenters for making this the very first step in a larger effort. It is now my pleasure to introduce you to our first speaker. Ken Norton is the Executive Director of the New Hampshire chapter of the National Alliance on Mental Illness. Ken led the development of NAMI New Hampshire's Connect Suicide Prevention Program, which is designated as a national best practice program in suicide prevention, intervention, and postvention. He is also a family member. Ken?
Great. Thank you all, and thank you, Richard, for SAMHSA hosting this and for EDC's participation, and Perry for your advocacy relative to families. And I'd like to start by taking a look at informed consent and in a broad category. And I'm going to read, there's a couple quotes that I'm going to use. I'm going to read them because I think it's important to give voice to those voices that have informed me and my practice. And this is a quote I heard from a suicide loss survivor at the American Association of Suicidology conference in 2006. When my father was diagnosed with cancer, the doctors told us he had a 40% chance of living 1 year. When my son was diagnosed with bipolar disorder, no one told us about the high correlation between the illness and suicide attempts. If we had known what to look for, he might still be alive today. I think every family dealing with mental illness should be informed of these risks. And I think that, this gives a nice perspective on what our role as treatment providers has been relative to families, which has essentially been to hold families kind of at arm's length. And do we engage them relative to the assessment process? Do we engage them in terms of crisis planning? And do we engage them relative to informed consent and what their role in an informed consent process might be? And obviously that would be important with minors under the age of 18, but I think it goes well beyond that as well. And if we look at the folks from the suicide prevention field, we've also had a fairly limited view of what families' roles are. And that view has been relative to kind of the focus on families as gatekeepers. And I know I myself and I've heard many of my peers say things like, if everyone knows the warning signs of suicide, we can save lives and prevent suicide deaths. But is that really enough? And I think that we really need to move beyond recognition, as this quote indicates. I knew my daughter was at risk. I called the school guidance counselor who met with her. I called to get an appointment with her therapist. They all said she was okay, but I knew she wasn't. She took her life 3 days later. And I think that speaks to that we need to be able to do more. We often talk about primary care providers and their lack of willingness to ask somebody if they're suicidal, because what if they say yes, they don't know what to do, or they don't have the time to do that. And I wonder if that same piece applies to us in the suicide prevention community. Do we not engage families because we really don't know what to say to them, or how to engage them, or how to better prepare them for dealing with risk? And what education can we have for them? How do we view them as partners and potential helpers? And I think barrier number one, or enemy number one, if you will, is HIPAA and confidentiality. And ironically, it's the Health Information Portability and Accountability Act. And it was never intended to be the wall that it has become misinterpreted to mean. And in fact, the Department of Health and Human Services clarified HIPAA in a letter to the nation following the Newtown shootings, in which they said essentially that a healthcare provider in good faith can provide necessary information to prevent or lessen a serious and imminent threat to the health or safety of the patient or others. And then it goes on to define that in more detail. But there's really a need for educating folks relative to that, and even the support staff and administrative staff. I can give a personal example with my family member where when there was a call left on our answering machine that there were appointments available at 2 o'clock, 3 o'clock, and 4 o'clock, and I called back to say, we'll take the 4 o'clock one. They were like, no, you can't confirm that appointment. Your family member has to call. And at the time, my family member was in a very rural area without access to a phone. And I also think that had I called their primary care provider's office, it would have been no question. Oh, okay, fine. I mean, I'm the transportation. How is that working? So I think that kind of leads me to the question, and it's a rhetorical question about, does HIPAA protect people's privacy, or does it contribute to stigma and the perception that mental illness is something to be ashamed of? And in New Hampshire, we've taken some steps to, which actually existed before HIPAA, to try to sorry, I don't know what's going on with my computer here. To try and to have some laws relative to, to provide laws that allow for or clarify when families can be disclosed for information. So we had a law that NAMI was involved in passing that allows for specific information to be given to families of caregivers of people with serious mental illness in certain circumstances. And that circumstance involves when there's when they've been hospitalized and are being released from the hospital, and particularly our state hospital, and when they're involved with a community mental health center. And that information is really limited to key pieces relative to medications and side effects or other warning signs. And New Hampshire's not alone in that. Oregon has passed similar provisions that even go a step further. They have a bill that requires hospitals to develop a protocol for connecting patients leaving a psychiatric inpatient admission with a friend or a family member. And that, it doesn't mean that it has to happen, but they need to have a protocol in place for how and when that will happen. And they also have a bill that clarifies for emergency department personnel that HIPAA allows for sharing information with families. So when we're thinking about how to engage families and natural supports, it's important to think about how can we, with that individual, assess what the level of their natural supports are. Have they shared their thoughts about suicide or their suicide attempts with anybody? Who would they call in the middle of the night to get help from? Are they estranged from their family? And is that estrangement a healthy situation or perhaps not a healthy situation? And and certainly looking at the fact that withdrawal and isolation can certainly be key risk factors and warning signs for suicide and for suicide risk. If we look at sorry, having trouble advancing here. If we look at Thomas Joyner's theory about suicide prevention, that he's identified perceived burdenness as an important risk factor for suicide. And the focus here is on that perception piece, that while there may not be burdensomeness, it's that perception by that individual that they become a burden to their family. So is there the way to assess that and maybe clarify and have that opportunity to address and reduce those perceptions with that individual? So the next key thing is about safety planning, and this is really the place where families should be engaged. Safety planning should be person-centered, and it really needs to engage that individual in coming up with development of their plan, and a plan that is specific to them. What are their personal warning signs for when they're at risk? What would somebody else see, or what would give them pause? What is their quote-unquote personal medicine that they might use? Is it walking the dog? Is it taking a bath? Is it listening to a favorite song? Is it watching a movie? What are those things that they do that helps them relax when they're in crisis, and how to get that together into a plan? And then coming up with that specific plan for them that also identifies local resources and certainly should also include the National Suicide Prevention Lifeline number as well as part of that plan, and hopefully include engaging families as a part of that too. And then what's the role that lethal means restriction plays with that, and how can we include lethal means restriction in that process of safety planning? I want to be clear that safety plans are not quote-unquote no-harm safety contracts. There is no research that supports the use of no-harm contracts are helpful in preventing suicide. I guess in the reverse, the only thing where they might be helpful is knowing if somebody would refuse to sign that. But signing one doesn't in any way ensure somebody's safety, nor does it protect the clinician or the providers from liability. And I would also add that that while these were quite popular at a point in time, that that they fail to engage the families or the natural resources in any way in the involvement about safety planning. So when we talk about lethal means restriction, it is part of the national strategy for suicide prevention, and we're looking at removal of the means that somebody might use to take their life. And that could be a temporary removal, it could be a permanent removal. Obviously firearms, given their lethality, are very important to remove from the home, but also unused prescription medications, car keys, maybe knives or some other things specific to that individual. And that lethal means restriction should include under what circumstances those things might be returned or who's going to hold them, and trying to be as specific as possible about it. One of the beauties of lethal means restriction is that anyone can do it. It isn't just a clinician or a provider, and certainly families are key to often following through with that actual process of removing the lethal means. And there's a great training that's available for free on the Suicide Prevention Resource Center, sprc.org website. It's called COM. It's Counseling on Access to Lethal Means Training. So when we are engaging families, what should we be thinking about, and how can we engage them in this process? And I think the first thing is to be careful not to pressure family members into a situation that's not manageable, e.g. that they might be asked to provide 24/7 supervision for somebody that's at high risk. And I think one of the key things, and this gets back to my first slide about informed consent, is to work with the patient or the client to get a signed release of information. And the emphasis there is on work. It isn't just presenting them with this form and saying, are you interested in signing this form so we can release information to your family. It's talking with them about under what circumstances. If they say no, exploring that further. What does that mean? Here's the information that we would provide. It's limited to this. Would you be comfortable with that? It's only under these circumstances. And I think that when we really work to explain that to the person and find out what some of the parameters are, that there's a way to get to yes, which is a critical piece to this in terms of having some type of signed release. And, I think it's also important, as Perry talked about, for many families that have been through suicide attempts or serious mental illness with their loved ones, they're traumatized, they're stressed. I can certainly say that from personal experience, and helping them get connected with support can be really key, or with education. So, you know, a couple of other things relative to families is that they needn't suffer or worry alone, that they should really get connected with other families that might be in similar situations, that they should educate themselves about suicide and mental illness and related challenges for their loved ones. NAMI has some great family educational programs around that, although I think, as has been mentioned, as a field, we really have done very little relative to specific programs for families who have a loved one who is at high risk or who's already made a suicide attempt. And certainly to be gentle with yourself and your loved one. And I think probably the most important advice that we can give is to just be with that person and to listen and to don't feel like, you know, you have to have the right answer or to fix it. And certainly we always want to use the lifeline 1-800-273-8255 as a resource. There is an After an Attempt brochure that is available, and that was done by NAMI together with the SPRC and SAMHSA. It is part of a series. There are 3, and the other 2 are one for After an Attempt for emergency department staff and After an Attempt for that individual who made an attempt. And it's a great guide for how to interact with families following an attempt. And some of the questions for providers, I think, there's questions for providers and questions for families to ask providers. And I think those questions can be very informative relative to the types of things that providers should be talking with families about. Like, why did you make the decision that you did about my family member and their treatment? If they're going to be released, what was that based on, or why? If they're going to be admitted, is there a follow-up appointment scheduled? What's my role as a family member in the aftercare or safety plan? So some of those questions are really important. Questions, you know, also that the family might ask of their loved one, or for a provider as well. Like, what's changed since your suicidal feelings or actions began? How can we know that things are different? So those brochures are a great resource for folks. And then, you know, how can we incorporate this into our practice? And in Oregon, the Circles of Support has built in a checklist that can be included in a medical record, and sort of how do we go through some of these pieces about communicating with family? What are their resources? Have they been informed about what some of the risks are? Have they been informed of the safety plan and what their role in the safety plan is? And then coordinating provision of care. Do they know when the appointment is? Are they going to follow up with that appointment, et cetera, et cetera? And then the last thing, we in the Connect program do a lot of postvention work, and while responding to a suicide is never a pleasant incident, it can be a real learning experience, and sadly a learning experience. But what can, for those of you that have experienced the suicide of a client, I think you know, in looking at the retroscope, it's always 20/20, but how can we be informed by a suicide death about what we might have done differently? How we could have engaged the family or the natural support system, how we could have gotten a release of information or worked to understand the circumstances about what information might be exchanged. And then lastly, on a personal note, I would just say having had a family member who has spent a lot of time in crisis and at high risk for suicide, that it is extremely stressful, as Perry had indicated before. And I don't have a lot of words of wisdom except to say that I oftentimes found myself going to bed saying the Serenity Prayer and waking up in the middle of the night and saying the Serenity Prayer and saying it first thing in the morning. What is it that I can control? And what is it that I can't control? And what is it that I can do? And then, you know, on a more personal note, I kind of stopped saying that I loved you to my family member. I didn't stop entirely, but my message changed to I believe in you, because I knew that they knew that I loved them, but it was clear that they didn't believe in themselves, and that was just one of the strategies that I used during that period of time. So thank you, and these are some resources that are available. Support and educational programs through NAMI, the NAMI Connect website, lethal means restriction, the After an Attempt brochure, and the National Suicide Prevention Lifeline.
Thank you, Ken. And it's now my pleasure to introduce Rajeev Ramchand, who is the Senior Behavioral Scientist with the RAND Corporation. He is an epidemiologist who studies the prevalence, prevention, and treatment of mental health and substance abuse disorders in at-risk populations and communities, with a specific focus on suicide and suicide prevention.
Thanks so much, Perry, and I want to echo Perry and Ken's thanks to SAMHSA for convening us together to here talk about this. I have been studying suicide and suicide prevention for around a decade now, and I too have noticed a lack of kind of discussion about integrating families into caring for people who are at suicide risk and who may have some chronic suicidality. My talk today, I'm going to use my time a little bit differently than Ken, and a little bit worried that I'm preaching to the choir, but I've been thinking about this a lot, and I hope what I can do is articulate why I believe that engaging family members for people at risk of suicide has been a neglected suicide prevention strategy, and why I'm going to end with a hypothesis as opposed to beginning with a hypothesis and then providing the research evidence behind what we found. I'm going to end with a hypothesis and really show you the map of how I got there. So my main points for those who want to space off or who don't have the capacity to handle right now, I want to talk about the evidence we know that mental health problems do increase the risk for suicide, that they are a risk factor for suicide. But then I want to show some data to really hone in on the point that has been made already, that caring for someone with a mental health problem can be stressful for the caregiver. We have some data, and I'm going to show you some data that supports that claim. But then I'm going to turn it around a little bit and say that some of our suicide prevention strategies, and Ken really kind of preface this a little bit, that some of our suicide prevention strategies may actually lack relevance for persons with chronic suicide risk. And then my hypothesis that supporting families of persons with mental health problems can save lives. So one thing that we do know is that suicide increases risk, or mental health problems increase risk for suicide. And I've shown some of the strongest evidence to date based on a review of the literature. And you don't need to understand really what this SMR means necessarily, but that anything above 0 indicates that an increased mortality risk essentially for people with the condition. So you'll see that among people who die by suicide, for you see increased rates of suicide among people with schizophrenia, with depression, borderline personality disorder, bipolar, and then in women you see evidence for both eating disorders, anorexia, and bulimia. So we know that this already exists. We also know that there are other risk factors, of course, but we know that mental health contributes in significant ways to suicide risk. But we also hear often that relationship discord is also a risk factor for suicide risk. And sometimes in our research and when we run things like regression models, we compete the two against each other. We treat them as independent constructs between each other, relationship discord and mental health symptoms. So, and I show here significant relationship. This is from one of my own studies where we interviewed family members of people who recently died by suicide. And you'll see that I even do the same thing. I ask relationship status as completely independent from a section on mental health status. So I've done the same thing, but in analyzing that data, it really made me reconsider this approach. So what in contrast to thinking about them as independent things, I really think that it obscures this dynamic relationship. And what I mean there is that mental health symptoms exhibited by a person can actually increase or be a causal factor of relationship discord, which can then re-emphasize or worsen the original person's mental health symptoms to start with. So unless we intervene in that cyclical process, you can see it just spiraling downwards and continuously getting worse. Both the discord between the two partners or the pair, it could be a parent and a child, it could be friends, it could be a spouse relationship. We see that worsens, and we then see that that could also influence the person's mental health system or symptoms. So we see this potential spiraling out of control. So to move on to the fact that there's some evidence to support this, that caring for somebody with mental health symptoms is a problem, I'm going to draw from a study that we did in 2014 on a national survey of caregivers. So this study was focused on military caregivers, and so we identified people who were caring for somebody informally, so not in a paid way. And we were really focused on the military caregiver population. And so that could be of interest, and I'll show data for military and veteran caregivers for those who are engaged in working with those communities. But really, if you're not, we also interviewed as many caregivers as we could, so non-military caregivers as well. And the results really hold true, so it should be of relevance to everyone. So we conducted the survey. This tells you where we spoke to people. It was all across the country. And what we find is that 9% of U.S. adults report being caregivers at some point in their lives. That equates to around 20 million individuals, at some point in the past year, I should say. So that equates to around 20 million individuals. These are the types of conditions that we heard people are caring for. So a lot of it has focused on that third bar chart down, chronic conditions like cancer. So you see 77% of pre-9/11 caregivers and 63% of civilian caregivers report that they're caring for people with things like cancer or other chronic conditions. But what you'll also notice is that around a third of caregivers to pre-9/11 military veterans as well as caregivers to non-veterans are caring for somebody who they report having a behavioral health problem, so a mental health condition. Again, this has been a neglected population in the past, and so it just kind of says that there's a group of people who are out there caring for people with behavioral health conditions, and it's around a third, a little bit higher, but you can just estimate it's around a third of the 9% of caregivers who are currently in the United States. So traditionally, how we've measured caregiver burden and the activities of caregivers is we ask about things like help with activities of daily living, so things like bathing or walking or standing up, sitting down, or then we kind of will go a little bit further and talk about instrumental activities of daily living, getting to appointments, things of that nature. We were cognizant of the fact that those might not capture the actual tasks that people are performing who are caring for individuals with behavioral health conditions. So we asked an additional question. We just asked a very broad question. Are you helping your care recipient, the person that you're caring for, cope with stressful situations? And you'll see that between 50%, around 50% to 3/4 of the caregivers we spoke to reported that they were helping their loved one, the person they were caring for, help with these stressful situations. So they were performing activities that have been previously really not considered as part of the caregiving literature when talking about the roles and responsibilities that caregivers assume. But we also found that this caregiving has a toll. So what we found is that of those that we interviewed, compared to non-caregivers, all caregivers, regardless of whether they were serving military personnel, veterans, or non-veterans, faced an increased criteria for probable depression themselves. So around 40% of our post-9/11 and around 1 in 5 of caregivers who are not caring for somebody in the military met criteria for depression themselves, which was elevated from non-caregivers. And when we looked at why, what were some of the factors that increased risk for depression, we looked at a whole host of factors, all of those things that you see on the right-hand side, things like demographics, education level, household income, relationship to the care recipient. The ones that emerged were we saw some demographic differences, which we were prepared for. We saw income characteristics, which we were prepared for. We know that that's consistent with trends. We also spent time spent caregiving. So the more individuals reported that they spent caring for their loved one, the more that increased their risk for depression themselves. But also, and I wanted to highlight in this red, those caregivers who reported that they were helping the care recipient cope with stressful situations, that was a task that they were doing as part of their caregiving duties, that increased their risk for depression themselves. So it's just providing evidence of the spiraling condition that I was talking about before, that you're caring for somebody with behavioral health conditions, it's causing depression in yourself, and that depression that you're experiencing as a caregiver can cause further strain on your relationship with the person that you're supposed to be supporting. I want to turn now to talk about, now that I've kind of provided the evidence that caring for somebody with a behavioral health condition can have real ramifications, real mental health ramifications to the individual themselves, I want to talk about some of what we know about how we should prevent suicide, especially from a universal approach. One of the most popular things that I've seen is activities or brochures or posters that promote the warning signs for suicide, and you'll see one example from the Navy right here. And the question I want to ask that is, for these individuals who are in these dynamic relationships with somebody with a behavioral health condition who may know that the person is at risk for suicide, is promoting the warning signs an effective strategy for families of these individuals? And for two reasons, I'm going to say it's not, and I'm going to show you evidence of the two. The first is that, well, what do you do with these warning signs? Generally, what the advice is that's given in these awareness campaigns is that we find somebody with a warning sign, we intervene, and we usher them into care. And what I'm going to show and hopefully tell you is that a lot of people who die by suicide actually are already in care, and I'm going to show you some evidence. So it may not be that they need to initiate care at that time. But secondly, and perhaps more importantly, I'm going to show you some preliminary pilot data that suggests that these warning signs might not actually be valid for some of the people who die by suicide. So this is data from 2014, and it was from a large cohort study that looked at healthcare visits in the 4 weeks prior to suicide death among individuals who later died by suicide. And what you'll see is that 50% of those who died by suicide had actually seen somebody in the healthcare setting within a month before dying. You'll see that a quarter of those were actually saw somebody in a mental health care capacity. So around a fourth of the people who died by suicide had seen a mental health care provider within the 4 months prior to their death. This is from a large study, but it's consistent with data that we've seen from a number of other studies that are much smaller in scope. So it's that there's a significant portion of people who are at risk for suicide, who die by suicide, who are already engaged in mental health care. But further, and this is the point that I want to make, is this issue about the warning signs. So these are the is path warm warning signs that many of you know about, things like ideation, substance use, purposelessness. And we conducted interviews with family members of 17 suicides in the New Orleans area over the course of a year. And we asked them about these warning signs, and we asked them when they occurred. Specifically, did you witness these signs within a week before the person died by suicide? And did you witness these symptoms or these signs within 30 days before the death? And what you'll see in this chart is that many of the warning signs were observed, but they didn't indicate imminent risk because not only were they observed in the 7 days before death, but they were also observed in the 30 days before death. So it wasn't that the substance use increased or that the person was hopelessness and suddenly expressed a feeling of hopelessness in the acute days before suicide, but that for the past month they had really, to the individual telling us, for the past month they had been exhibiting signs of hopelessness. They had been exhibiting mood changes. They were being reckless. All of these things that we think of as warning signs for that immediate time before death actually weren't predictive of the suicide death. So I'd like to posit that we don't really know to tell family members what they should be looking out for to indicate that somebody is suicidal right now or in an acute stage. And that's something that I think we need to do a lot more research on. So as I said before, I'm going to end with a hypothesis. And my hypothesis is I hope that from the data we've provided, or that I've provided, that we could say that supporting caregivers of those with mental health problems or recurrent or chronic suicidality can prevent suicide. But that's a hypothesis that I can't prove right now, but I think that we need to prove it, and I think that that's where research is needed. And so what that means, and I think that I'm setting up the next speaker, is that we need to develop and test interventions specifically directed for caregivers, but also ones that include caregivers in the treatment that the person is receiving. And these are very distinct. So ones that both include family members, so a traditional family therapy you might think of, but then treatments that are directed towards those individuals who are caregivers themselves, exclusive of their relationship with the person. The second is that we need to disseminate the programs that work. So often in research we find good programs, they're great programs, but they remain the scope of the programs remains small. And we need to really pursue an aggressive strategy for when we know something works, when it's evidence-based, when we have some research findings behind it, that we get it out into the community, that we make sure that people across the United States and abroad are aware of these programs and that they have access to them. And then finally, I think that it goes without saying is that we really need to include and engage survivors with lived experience in our suicide prevention efforts. My interviews with the 17 family members of those people who lost their lives in New Orleans were extremely insightful, but we need to ensure that family members can tell us what they needed during times of distress, what they need during times of distress, so that we can respond and really tailor our interventions to meet those needs. So that's what I had to share with you today. Thanks so much. I look forward to the questions, and I really hope that, as was said earlier, that this is the beginning of a dialogue about how we can support families to really prevent the suicides from the continuous increase that we are currently experiencing. So thanks so much.
Thank you, Rajeev. It's now my pleasure to introduce Alan Ferzetti, who is the Director of the DBT Boys Program and Director of Training and Family Services for 3 East programs at McLean Hospital, and with an appointment pending, Associate Professor at Harvard Medical School. He is also the Director of Research for the National Education Alliance for Borderline Personality Disorder.
Thanks so much, Perry, for the introduction, and thanks not only to Perry but to all the people at SAMHSA for putting this, I think, very important step towards suicide prevention into a webinar to get us started. Indeed, I want to pick up, thanks so much, Rajeev, for that setup, because I want to talk about a program that we've been running that for now 16 years called Family Connections. It's a program for parents. I'm going to talk about particularly a program for parents, but it's been a program for parents and partners and others of people with borderline personality disorder, and more recently also now a program for people who are suicidal or at risk for suicide. I think the rationale for this has already been well covered, so I just want to review a little bit about the relationship not only between family functioning and, say, individual psychopathology and distress and disorder, which I think has been well covered, but specifically look at suicidality. So we looked at a study which actually was a randomized trial looking at 2 different treatments for suicidality in teens and young adults. And we tracked their family functioning over time, before treatment, during treatment, and then following treatment, for both treatments. And this was a treatment study that provided no particular family interventions. This was not a family intervention study, it was an individual treatment study. And what we found was that for those people in the study, regardless of which treatment they were in, that family functioning mediated their outcomes. What that means is that for people for whom family functioning improved as they went through individual treatment, their outcomes were considerably better than if their family functioning didn't get much better over the course of their individual treatment. So this is just further evidence that Indeed, this idea of individual well-being and family well-being are not independent. They're closely linked. And that's on the one hand, makes research on this more complicated than likely has been evident for many, many years. On the other hand, it means that we have wonderful opportunities to intervene in efficient and very effective ways. So even though the suffering of families and their role in treatment has largely been ignored, we have lots of evidence now that it's folly to ignore it, and in fact efficient and effective instead to include families. So I want to talk about some ways that we might do that. So one is our program we call Family Connections. Family Connections is a program that my dear friend and colleague Perry Hoffman and I started a long time ago. We noticed that there were access problems in the system for people with borderline personality disorder, people who were highly suicidal and self-harming, that didn't have good access to care. Their families, their parents, and their partners didn't have good access to care. And of course, it was our belief from the beginning that their well-being mattered independently and likely rolled around and had an impact on the person identified as the patient. So we constructed Family Connections really with three important and somewhat separate goals. The first was to provide state-of-the-art psychoeducation and family psychoeducation. So information about disorders, information about treatments, information about family functioning, diagrams and models and data in particular, like what kinds of things would be helpful, what kinds of things might not be so helpful. As you can imagine, psychoeducation varies over time as we learn more. The part of the program that we call psychoeducation has changed quite a bit. We know quite a bit more now in 2018 than we did in 2001 or 2002 when we started this program. The second goal of Family Connections has to do with teaching family members skills. We see problems in families not as something that families should be blamed for or patients should be blamed for, but rather as problems that require skills. Somebody needs something to be able to do something in a different way, and the person doesn't have the skills to do it. So they may be individual skills, things like how to manage emotion, how to figure out actually what you want and communicate that clearly, being able to pay attention without becoming too reactive to what you hear. Those are all individual skills. And of course, family skills start to become what we do with information that we get from our loved ones, how to pay attention to other people, how to actually incorporate that into our own emotion and manage our emotion as we listen, to be able to respond in a much more validating, understanding way, even when we're scared or upset or don't like something. And when it comes in particular to parents and children, how to be effective in helping kids do things that are safer, more effective, without destroying the relationship. And then because this is a group program, Family Connections has always been something that's been done in groups, there's an element of social support, being able to come together with other parents and other partners who have loved ones with the same kinds of problems. One of the most common things we hear early on in our Family Connections programs is how surprised people are, how many months or years they felt like they must have been the only person in the world with these kinds of difficulties. And to be able to join a group with people who have similar kinds of issues and similar kinds of struggles, to be able to help and support each other is very important. And so this increased social support helps them create a network of social support that often endures well after Family Connections formally ends. Now, let's bring our attention back briefly to suicidality. Suicidality, of course, is the large umbrella term for suicidal thinking, suicidal urges, suicidal attempts. As you saw in the last presentation, or maybe it was the first one, sorry, suicide unfortunately shows up in a lot of different diagnostic groups. It's not just one diagnosis. And so for so long, we thought about treating suicide only inside the diagnosis itself, but that may be a very 20th century idea. And so the idea of thinking about suicidality as a transdiagnostic problem or a transdiagnostic phenomenon, meaning transdiagnostic means it's across different diagnoses. The problem actually might be very similar, even though different people may meet criteria for different diagnoses. Or in fact, sometimes may not meet criteria for any diagnosis. And given that as many as 3/4 of the people who have died by suicide haven't had contact with a mental health professional in the last month, it may be that many, many, many people are not diagnosed and maybe don't even meet the criteria for a diagnosis. However, that doesn't mean that suicidality isn't a very severe problem. Of course it is. And so thinking about it transdiagnostically might get us out of the handcuffs that thinking diagnostically might put us in. When we do that, we recognize that therefore we're not limited to think about the psychological or the biological concomitants, the things that show up with a specific diagnosis. So someone could be suicidal and be depressed or have an eating disorder or substance use disorder, borderline personality disorder, or many other problems, or many of these problems all put together at the same time. Now you'll notice in our little triangle here of psychological, biological, and social that most treatments are geared to the psychological or the biological. The biological, of course, are medicines and other biological interventions. And of course, there isn't really any biological intervention for suicidality per se, at least not directly. Of course, helping people be less depressed or get off substances helps reduce suicidality. Psychologically, we can say the same thing, that there are many diagnoses here, and there are interventions, psychological ones, specifically for suicidality. Yet here we are in 2018, and most of our interventions don't include the social, in particular the family component. And I would add here, culture and other relationships are important as well. But families are often readily available, not always. Sometimes their absence is part of the problem. But when they are available, as was just noted by, I think, both Ken and Rajeev, that they're not included. They're not included in treatment most of the time. And that could be because of things like misunderstandings about HIPAA, or it could simply be that therapists, social workers, psychologists, psychiatrists don't know how to incorporate families into treatment, don't know enough about that, even though there's a fair amount of information available. We get so focused on learning how to treat a specific diagnosis that it's only recently that people have begun to think transdiagnostically. So by bringing the social in, the social, of course, affects the biological. The social affects the psychological, and vice versa. And we're really limiting our ability to be effective when we cut off a full third of these three factors, because they actually influence each other in such an enormous way. So Family Connections is a program that typically, when we started out, was a 12-week weekly program for about 2 hours. More recently, in order to try to increase access, we've also turned it into an intensive weekend where people can get a lot of the skills and education and some of the social support by coming all day on say a Saturday and Sunday, or 2 Saturdays in a row, split into 2 weekends, that kind of thing. Family Connections is a very grassroots program. It's led by trained family members and or professionals in the United States for reasons having to do with the way that our healthcare system is structured. It's most often family members. And we train them up. We train them up for free within the National Education Alliance for Borderline Personality Disorder. And then the idea is that they go out and they offer Family Connections programs to family members who need them for free. So there's no cost to participate, which removes almost all the significant barriers other than geographic ones to having access. And of course, with telephones and internet connections, really the barriers to participate come down and access just goes way up. So at this point, we've lost count at how many people in the U.S. have taken it. Thousands and thousands of people have participated, and Family Connections is now widely available, not only in the United States, but we think at least 21 other countries offer Family Connections. Now this is significant because by treating family members separately, and this was of course a point that Rajeev was making at the end of his presentation, that's in addition to including family members in treatment, this is a program for family members to come to on their own. And of course the idea is, and I'll talk about this in a few minutes, is that's a win-win. It's good for the family members who participate, but it's also good for their loved ones. I'll come back to that. But first I want to talk just for a minute about what some of the research data look like from Family Connections. At the moment, there are 5 published studies and several more studies in the pipeline to being published. 2 of those are published by our group, led by Perry Hoffman and me, but others have been published by other people who have nothing to do with its development and certainly aren't biased in any way. They all show significant improvements across all the important areas that we hypothesized for family members who participated. I want to give you one example. I don't want to run through 5 studies. That would take much too long. But the very first study we did, which by the way was in the beginning where we hardly knew what we were doing, so is the most conservative in terms of its outcomes. We actually have better and better outcomes as time goes on, and we've learned how to do a better job, improved our materials, improved our teaching, and so forth. But so study 1's a pretty good example of conservative outcomes. And this was published in 2005. Now, one of the variables that we were interested in measuring was grief. And that might seem like an odd thing because, of course, the vast majority of participants have loved ones who are still alive, although they've made suicide attempts. But the grief here is the idea that their life and the life of their loved ones is not what they planned. It's not what they set out hoping for. And so there's an enormous loss around expectations and hope and trajectories. And being able to acknowledge those losses, even though the person's very much still alive and we hope is going to have a fantastic life, as time goes on, things are going to get better and better, we hope, there's still a lot of grieving involved. And as you can see from this graph, grieving starts the orange. You'll see several slides here that have the same kind of color coding. The orange is before taking Family Connections, the yellow is after, and then the green is 6 months later after the program has stopped. And what you see here is this pattern of things getting considerably better from before to after taking Family Connections, and then improvements continuing into the future, which suggests that some of the reasons that things are getting better is because people are learning how to adapt their skills and their ways of managing the situation with their loved ones. It's not just a function of social support, because the social support ends at the end of the group. But the gains generally continue well after a Family Connection ends, suggesting that people are learning a lot and moving forward and using their new skills into the future. If we look at changes in general psychological distress and depression, and you see the same pattern, significant improvements after Family Connections with continued improvements into the future. We're also interested in this concept of burden that was mentioned, I think, by Ken earlier, that being perceived as a burden is one of the risk factors for suicidality. Well, we want to work on people not feeling like their loved one is a burden to them and alleviating their burden. Even though they may still be in some kind of a caregiver role, we want to manage that role to reduce its burden significantly. And as you can see, and these are all significant improvements from pre to post, and then an even bigger reduction in the follow-up period. Again, really good improvements over time. The flip side of this, of course, in terms of not just reducing problem areas, but also trying to improve a sense of mastery or empowerment, is very important for caregivers. People who have suicidal loved ones, not only is that tragic to just have the suffering of someone you love be so close, but it also, people experience this burden, they experience distress, they experience a lot of grief, and they feel very disempowered, like my life is not my own. I've got to be on call to my loved one, I've got to watch and be vigilant, I've got to do this, I've got to do that. I just don't have any power in my own life. And of course, we're trying with Family Connections to help people be re-empowered without in any way doing anything that's unhelpful to their loved one who is suicidal or is otherwise struggling. And as you can see from this graph, empowerment and mastery goes up quite a bit from before to after Family Connections and continues in the upward direction even in the follow-up period. So this is really good news, that we have a program that's had tens of thousands of participants worldwide now, with half a dozen studies or more that show that there are really big improvements. And it's free. So, of course, we've been trying to disseminate this program now for quite a few years reasonably successfully. And, of course, our goal is to make it even more available to families and family members who need it. Now, let's think further about suicidality. Now, one of the things about suicidality as a transdiagnostic concept is to say something, I want to say something that I think is kind of obvious. People don't kill themselves when their experience is that their life is good or going to get better. People think about killing themselves or try to kill themselves when they reach the end of their rope and they're very miserable and don't perceive that it's going to change. Now, that's an emotional state that we often refer to as emotion dysregulation. The idea of emotion dysregulation is that when we're dysregulated, the only thing that's really on our mind is getting rid of the pain. And it doesn't really matter to us at that moment what the medium or long-term consequences are for that. So a person might use drugs or be aggressive or self-harm or attempt suicide, not really caring about the negative consequences of those acts. They may all be designed to simply find a way to get some temporary relief. And of course, in the case of suicide, it's not temporary. But at that moment, people don't really care. It feels so awful. So we've got to think about this idea of emotion dysregulation and how social interactions, what the social context for emotion dysregulation is. Now, this is a pretty controversial, in some ways, idea, because we live in times that see emotion as being inside the person. But we know from hundreds and hundreds of studies that there are all kinds of social events and social processes that have a big impact on other people's emotions and are in turn affected by the expression of emotion of other people. So that's just another way of picking up the earlier slide that before it was the relationship between family distress and individual distress, and I want to make that even more specific, that individuals can be dysregulated and vulnerable to getting dysregulated. That has an impact socially on other people. And when people are dysregulated, they're not calm. They're not able to express their experience in easy to understand ways. They can be very off-putting. They can be demanding. They can be overwhelmingly sad and depressing and difficult to manage. And it's easy for people to misunderstand their experience and blame them, or just misunderstand and tell them it's easier than it really is, or they ought to do X, Y, or Z when they've tried X, Y, or Z 500 times. And that invalidating response of course, results in increased negative emotion. Everybody knows that, and I'll come back to a slide about that in a minute. So we call this a transaction, right? Because what one person does, person A, has a big impact on person B, and what person B does has an impact on person A. And it kind of goes around and around. It's not really rocket science. That part's not controversial. But when we try to put it into terms of emotion dysregulation and suicidality, now it sounds maybe complicated. Now, of course, we're not blaming anybody. There's no blame here. People are doing the best they can in this model. It's just that it's hard and people get stuck in these transactions. So a healthy transaction, so the person on the top here, would have some self-awareness, okay, and some situation awareness. Like, I'm feeling this, I'm wanting that, and this is the situation, and manage and be aware of his or her emotions. And they would be what we call primary emotions. They make sense in that context. So if it's kind of a dangerous situation, you feel scared. If it's a situation where you're not getting what you want, you keep working at it, you feel frustrated. If you're working hard and you get something that you've been working toward, you feel joy, and so forth and so on. And of course, because you're regulated, that's this top part, the expression of your emotion and the expression of what you're wanting and thinking and feeling and doing is all connected. It makes sense. It's easy to understand. And so the other person, so now we'll go down that left arrow to the bottom person, that person's aware and it's easy to understand. Oh, I get it. That happened. You were driving along, somebody cut you off, and that was really scary. See, that makes sense. That's not hard to understand, right? But if you come home and you're yelling about the boss who just gave you a raise, it's hard to understand. And in fact, it may be just leftover fear from somebody just cutting you off on the road. And so this awareness and understanding of the other keeps the second person fairly regulated, him or herself. It's easy to understand and then say things that are quite naturally validating. Like, that makes sense. Oh, geesh, I feel that way too. Of course you'd want to do that. Those kinds of validating statements that actually everybody loves and actually have a profound impact on our well-being. Now, unfortunately, the problematic transactions go differently. The person is not so self-aware, but instead is judgmental, which distorts thinking. Emotions get higher and higher, and what comes out isn't accurate. It doesn't make sense. There is a sensible thing that could come out. It just doesn't. And then the other person maybe feels attacked, gets judgmental back, gets angry, and invalidates, which, of course, jacks the other person's emotion up some more. And this kind of continues. Now, this is just a graph that shows that even for very ordinary people, okay, the green line is when we stress people out, if we also validate their stress, like it makes sense that you feel uncomfortable, it makes sense that you're stressed out, that actually even while we continue to stress them out, they feel better. But the red line shows that if they're stressed out and you invalidate them, you don't tell them that their experience makes sense, they can't get used to the stress. The stress continues unabated. And of course, that's part of what there's no better evidence for the social influence of emotion than this. Everybody's the same here, the people on the red line and the green line. The only difference is that the person in the experiment is validating in the case of the people on the green line and invalidating the people on the red line. So just to summarize some results from our study with parents of teens, I want you to see that the parent skill group, the family connections group, that's the green, that the kids showed significantly better improvements than a wait list. Okay, these were randomly assigned from pre to post, from time 1 to time 2. Similarly, in terms of ratings of parent invalidation, they rated their parents as being much less invalidating by time 2 after the parents went through this skill and support group. And they felt much more like their parents were much more available if their parents went through the parent skill group, the family connections. And the kids in turn showed fewer problems, that's the green, with regulating their emotion over time. So this validating, invalidating piece is a very important mediator that actually has a direct impact on teenagers' emotions. And, okay, parent improvements, more validating, less invalidating, their kids showed more improvements in their emotion regulation and more improvements in terms of being less depressed. So there are lots of things connected to, and I'm not going to run through them all, emotion dysregulation, but I want to emphasize that the social context for emotion dysregulation is something that families can have an enormous impact on. So conclusions, if we think transactionally, we recognize that we can help parents and partners. What's good for them is good for their loved ones. If we think transdiagnostically, we can think about emotion regulation and validation as a key tool socially to help regulate people. Of course, there are other factors, but these are very potent ones. And regardless, including parents and other loved ones in treatment and in other programs is really essential. And it's important to make access easy as well. So thanks very much for listening. I hope this has been helpful, and I'll turn the program back over to Perry, I think.
Great. Thank you, Alan. This is actually Carrie Nickerson from the Suicide Prevention Research Center. Thanks to all of our speakers for their wonderful presentations. So we're going to start the question and answer period of our webinar. So if you have any questions, please feel free to type those into that Q&A section on your screen. So, Alan, just a quick clarifying question. Someone has a question about whether there are Family Connections programs available to residents of New Hampshire or similar programs in New Hampshire.
There are. Short answer.
And how can people best find out about those?
Yeah, if they go to the NEA BPD website, and I'm sure that's here somewhere, click on the Family Connections site, they can just, there's a way that they can send a direct message to our coordinator saying, where they live and that they're looking for Family Connections, and then we'll do our very best to get them connected.
Great, thank you. And just a clarifying, just so there's no confusion, Ken, if you wanted to say anything more about this, feel free, but there is also, through NAMI, a National Connections program for peer support groups, and that isn't to be confused with the Family Connections program that we've been talking about here.
Right, family to family, yeah, different.
But
great.
There's to family, but there's also a national NAMI program called Connections that is a support group for peer-to-peer. So
right, well, right, of course.
A little confusing with the names.
And Ken, is there anything else that you would like to share? Certainly we've heard some great examples of some programs for supporting families, but is there anything else you would want to share about resources both nationally and through local chapters, your chapter of NAMI?
Well, NAMI is a national organization and has chapters around the country, and the programming differs from chapter to chapter, but typically what's available are some types of educational programs and support groups, and I think that the program, the Family Connections program that Alan has detailed, is fabulous. And I would just say that, in my experience, both personally as a family member and professionally, that there's a lot of wisdom from other people with lived experience, whether that's people who have lived with suicidal thoughts or attempted suicide, or other family members who have had a person in that situation, or a loved one, or those caregivers. And connecting with that peer-to-peer wisdom and support, and knowing that you're not alone, is just really important, and encourage people to seek that out wherever they are in whatever way they can find that.
Great, thank you. Rajeev, there's a couple questions for you. In your findings that you listed, there seemed to be kind of a major jump in some findings about changes post 9/11. Some of the caregiver statistics seem to jump way up. Would you be able to say a little bit more about that?
Sure. Thanks. This is a great question. I wasn't planning on going into the military versus civilian caregiver distinction, but since there was that evidence there, I'll speak to it. Generally, in our study, what we found is that people who are caring for someone post 9/11 are very different than people who are caring for veterans from the pre-9/11 era or from or non-caregivers. So generally, the caregiving literature and research on caregivers and the overwhelming majority of caregivers in the United States are, generally speaking, adults who are caring for their elderly parents who are having things like, as I said before, chronic conditions like cancer, things like dementia. They don't necessarily live with their parents. They, take turns doing that. Now, this is really different from this group of, we estimate 5.5 million post 9/11 1.1 million post 9/11 caregivers. And this 1.1 million post 9/11 caregivers generally are spouses. They're living with the person that they're staying with. The post 9/11 caregiver care recipient are more likely to have behavioral conditions like post-traumatic stress disorder. So it's hard to group them together, even though I did it, but they're very distinct groups that have very unique challenges. They spend more time because they're living with the person, doing caregiving, assuming caregiving duties. So we assume that it's the combination of things like they're younger, they're married, so they have a different relationship, they're spending a lot of time with these caregiving duties, and they're caring for somebody with post-traumatic stress disorder or other behavioral conditions that really collectively elevate their risk for things like depression themselves and things of that nature.
Great, thank you. And for all of our presenters, is there any evidence-based ways that families can be engaged while their loved ones are actually in the ED? Are there lessons learned there that you may want to share?
I don't have any lessons learned. I think that I can respond to that a little bit in that I think that the question is actually a really astute one. I think that emergency departments are increasingly being recognized as places where we can really identify people who we may not know are at risk of suicide, and we can, so there's definitely a way to identify them. I think that now our challenge as a community is thinking of, once we've identified somebody in the emergency department, what's the standard of care? What are our operating procedures? How do we best care for that person that we've now identified as being at risk at suicide, who may have come in for a broken ankle or something like that? So I think we're figuring out what to do with the patient, him or herself, and I think that rather than, I would actually really advocate that rather than figuring out what to do with them and then as an afterthought think about what to do with their families and how to integrate their families, I think this discussion really propels us to think about the two concurrently. How do we treat the person and their family at the same time, and how do we integrate that care within the ED setting? I think this is an opportune time to actually look at that question and to develop standard policies and practices and procedures right now to do that.
This is Richard McKeon from SAMHSA. I'll just make a comment on that. Really based from my experience having run a psychiatric emergency service in years past. Because I think clearly in terms of evaluating and intervening with people at risk for suicide in the emergency room, families have a critical role to play on a number of different dimensions. One is, as part of the assessment is risk, that family members oftentimes will have vital information that has to be part of doing an informed suicide risk assessment. Also, I think one of the things that we need to move towards is that my experience was that most people in the emergency room who were seeing because of something related to suicide were willing to have their families contacted. And I think the larger problem were providers not asking for that. Granted, there'll be a smaller number of people who will refuse consent. But I think if we routinely ask for consent, I think in the majority of instances it's going to be there. And any kind of safety plan or treatment plan, whether the person gets admitted to the hospital or not, that has the active engagement of the family, I think my hypothesis would be our longer-term chances of success are going to be greater. So I think it's a really important question, and while we certainly need better data on it, I think there's a vital role for families to play. I'm going to be needing to leave the call, but James Wright will be closing for SAMHSA, and I'm so glad that so many people were on the call listening to these great presentations. The last time I looked, we had well over 400 people listening to the call.
Great.
This is
Thank
Ken,
you,
and I
Richard.
just want to echo what Rajeev and Richard said. 2 quick points. One, I think to Rajeev's point, I mean, we're seeing that this data shows that a number of those people who are dying by suicide who have had recent visits to the emergency room aren't necessarily presenting with mental health issues. And so there really is a need to screen beyond that. And then secondly, from my own personal experience relative to temporary removal of firearms, that, you know, you'll have families say, oh, the kids don't know where the guns are. And I say, you know, well, they probably, you think they don't know where you hide the Christmas presents either. And or there's sometimes a gender piece where the woman might not know that there are firearms in the home, and that's broad brush. But, you know, but I think engaging families and having these conversations is really key. I think that this has been a great presentation to be able to highlight some of these different strategies.
Great. Thank you so much to all of our presenters. I know there's several other questions, but unfortunately we are running very short on time. I did just want to remind folks there are several family members who've asked some questions about how to handle situations within their own families, and I just want to put a plug out there to please remember to reach out with any of the questions when you're concerned about a loved one to the National Suicide Prevention Lifeline. That's 1-800-273-8255 if you're here in the U.S. I know we have a couple international participants as well. So again, I just want to thank all of our participants. There's also been several questions about whether the slides will be posted after the event, and they will. They'll be posted on the Suicide Prevention Resource Center's website. That is sprc.org. And with that, I will turn it over to James Wright from SAMHSA to close us out.
Thank you, and just again want to thank all of the presenters, and we're really looking forward to continuing this this conversation. We do realize how important family voices are to those in suicidal crisis and the support they provide. So we look forward to that conversation, and if you do have other examples and are willing to share with us in the Suicide Prevention Resource Center, please reach out and also let us know if there are areas that you think would be beneficial to focus on in the future. So thank you everyone for participating in today's